Good evening. Can everyone, I think, hear me? I was going to put on my mask because I realized looking at the program that I'm the only gut doctor or belly doctor coming up here after all these infectious disease physicians. And I was watching the audience, and I think, Dr. Lindquist, you must have been very effective because the number of masks being put on increased throughout your talk. So that was an opportunity for a public health study that I think we should have done. I'm here at the request of the organizers to talk to you about a wide variety of viral hepatitis from a GI and liver perspective. But more than that, I focus my talk to try to be useful to primary care providers. Can I get a sense from the audience here, who is a primary care provider here? We have actually some specialists here, huh? Well, I was reading that recently when they looked at the number of hours a primary care provider would need in order to meet minimum guideline recommendations in a 24-hour day, do you know how many hours you would need? Yeah, you read that article, 27 hours. So I'm not here to add to that. I'm here to try to give you some insights into what I think are important highlights for viral hepatitis and the kind of questions I get from referring providers, both from GI as well as primary care. I think I'm having the same issue as you, Dr. Lindquist. Someone in the back, should I aim it somewhere else? Yeah, I have been doing that. All right. Well, we may be finishing early. This is kind of the easiest way to have the last speaker. All right, there we go. All right. Okay, here's the session objectives. You can read them. I'm going to try to go rather speedily. And as we go, please go ahead and stop me. There's a lot of data, and I'll have some anecdotes thrown in here. And I start with the why. Any talk should always try to engage you. Why are we even talking about this? You've heard a lot about infection control. I had a great refresher of mycobacterium listening in and also from the other speakers today. But I think for me, what keeps me and the GI and hepatologists and infectious disease in business is that viral hepatitis still remains, unfortunately, very relevant to everyone here. Eastern Washington, Idaho border, Oregon. This is not something that is happening in a foreign country. This is something that's happening in our backyards and will persist. And I think COVID will actually make things worse, as we'll see. This is a general overview. I'm not going to spend too much time. Anybody who has been through, I think, general medical education will have had this. But very briefly, as I explained to our learners, is that you can think of the A and the E. So the anus and the esophagus, these are the ends. These are the fecal-oral kind of approaches and the way you can get viral hepatitis A and E. And B, C, D are in the middle. So these are things that require blood or some type of exposure that way. And hepatitis are very similar in the way they present. They come asymptomatically to you in your clinic. These are the people who have mildly elevated liver enzymes or may come to you because they have some abnormal imaging studies or an ultrasound. And then in the ER, or when you're doing any hospitalist work, these are the patients who have severe right upper quadrant discomfort. They may have nonspecific nausea, vomiting, jaundice, and diarrhea. The constellation of symptoms that make up hepatitis is similar, whether or not it's from a virus or from a drug or from a toxin or some type of vascular compromise. So these symptoms are rather vague, but if you see them, you can think about whether or not they might have a hepatitis. And oftentimes, by the time you're being called, the ER will have gotten LFTs, and they're noted to be abnormal. Unfortunately, there's this bottom part here that it leads to acute liver failure and death, and these are the kinds of phone calls I get as a transplant hepatologist of the very sick person who comes in with an INR elevation, mental status changes, as well as transaminitis and jaundice. I like to start with this visual because I think it's easy to forget that this is not an acute issue for many patients. This is an issue that leads to cancer, especially for viral hepatitis B, C, and D. These are known carcinogens, and these have been declared as such. Hep B and C and D lead to cirrhosis and liver cancer, as you can so graphically see here. Now, this is a slide that I put in here mainly as a reference. I'm not going to go into it in depth, except to point out that viral hepatitis can have a protein features. That is, it has many variety of things that can be abnormal, in addition to having mildly abnormal liver enzymes to hepatitis. So you can have people having CNS symptoms. Dermatologists will have atypical dermatologic findings. Hematologists will see the easy patient with thrombocytopenia, and you can just send them back to primary care saying, this is just liver disease with splenomegaly. Vasculitides are notoriously difficult to diagnose, but this is most common with hepatitis C and B. Shifting to Hep C, again, the why. Why is it important for us? Because we still have several million people who have Hep C despite the treatment revolution that has occurred starting about 9 to 10 years ago. And the ones that are still in our community are the ones who are not diagnosed. And since 2007, the number of deaths from Hep C have still outweighed the HIV deaths. And I think this is a last line here is what we're shifting to, the hidden burden of disease worldwide that serves as a reservoir for ongoing transmission to the next generation, so the pregnant women with Hep C. In addition, it is a source of healthcare disparity. It disproportionately impacts those people who are on the margins of society. We've heard about those who are in prison, those who have lack of access to medical care, those who are underinsured or uninsured, who are houseless. These are the patients in whom there's a greater propensity for this disease. And because there's no vaccine, and yet there's a treatment to cure, this leads to a disparity of who's getting access and who's being cured. So there will still be patients who have Hep C for the next foreseeable, I think, several decades, despite a very ambitious program by the CDC and by the World Health Organization to try to eradicate viral hepatitis. In the real world, it's not going to go away. And COVID's impacting behaviors that will increase the prevalence and the incidence of acute viral hepatitis. So here is just some basic data. I don't think it is so helpful, but I put it in here for completeness. Why is that? Just to be aware, this is not an indolent disease in which you get exposed when you're a 6-year-old in a dairy farm. This is something in which you've recently been exposed through some type of nosocomial, blood exposure, sexual exposure. There's an average of several weeks. People can have symptoms, but note the small percentage. It's only about 20% that have symptoms. Everybody else is pretty much asymptomatic. And this is why many times patients may come to you. The little lady that seems to have no risk factors is surprised to be found to have cirrhosis and liver cancer, because maybe 40, 50 years ago, they had risk factors. In addition, the mortality rate, this is, I think, is an underestimation. The patient that you will see here in Eastern Oregon or in Eastern Washington, 65 to 70-year-old male with a history of Hep C with alcohol use history, who presents with abdominal pain and is found to have a large hepatic mass, did not know that they had hepatitis C, and now manifesting as cirrhosis and decompensation with hepatocellular carcinoma. This is unfortunately a very common story that we get. So what are some tests? I think this audience knows that, thankfully, this is very simple. The antibody test means that you've been exposed, but you need to confirm this with a Hep C RNA to confirm that you actually have viremia. If you remember from a couple slides back, up to 20% to 30% of people can be exposed to Hep C, but they may clear it on their own. And they typically do that within 6 months. So Hep C being positive, the antibody, is not tantamount to having active and current disease. It scares people, but it should be confirmed with Hep C RNA. Now this is a figure and a little graph that I think that you can look at. Mainly it is to say, don't stop at the antibody. And thankfully now many labs have reflex Hep C RNA, so that if you're the ordering physician, you will get both. Hep C antibody positive, confirmed with Hep C RNA, then you can tell the patient, you indeed do have Hep C. And then you can have a conversation about when the symptoms may or may not have started, when the risk factors may or may not have been experienced. And then it goes on to talk about linkage to care and treatment. Now, another why. So what if you have this disease? It's because it eventually will lead to cirrhosis, which I explain to people as scar tissue that leads to structural damage. That is, it affects the scaffolding. If we were describing this room as a liver, we would be starting to see the chairs being broken, the paint peeling off, the doors going off the hinges. But it's when we say the patient just has structural damage, it means, yeah, you could have ongoing damage to this room, but this room is still functional. It allows us to have a roof over our heads. It allows us to have this meeting. It's not too hot or too cold. But patients who then have cirrhosis decompensate, such that if this was a liver room, the room is no longer habitable. It is no longer useful. And that's how I explain to patients the difference that you go from structural damage over time, leading to cirrhosis, and that after you have cirrhosis, and an average of 12 to 20 years, you go to decompensation. That is, the room is no longer livable. And once that happens, within about 2 years on average, the room is collapsed. That is, the patient will die on average. HCC, or hepatocellular carcinoma, is feared, and it's at the top. Thankfully, unlike Hep B, you need to go through cirrhosis in order to have liver cancer, 99.5%. Hep B, on the other hand, as I'll talk about later, you can jump from just having acute infection to chronic infection and then straight to liver cancer. So that's quite scary. Thankfully for Hep C, we know that we don't need to screen for liver cancer until they hit cirrhosis. That's something to remember. Now, who should you screen? Pretty much there's recommendations now from major societies that everyone should be screened at least once. Now, I'm not going to go into it further because you've had multiple speakers talk to you about population health, and I put this for your reference, except to say if you think about it, you should screen. Now, unlike Hep B, the kind of conversation we have with patients with Hep C is very positive. That is, if they can come to your clinic, they can be cured. This is a disease that's not like diabetes or hypertension. You can cure them. And if you cure them, you can have this dialogue that planting hope. You will bend the curve heading toward cirrhosis. You will bend the curve heading toward liver cancer and early death. And this is durable. There's good data for that. Now, I put in here this last line about sustained virologic response. I think that's just fancy talk that doctors like to put in to make something sound fancy, but all it means is that you treated the patient and you cured them. I don't know why we don't just use that word cured, but we use this sustained virological response. But this predated my time, 40 years ago. But if you see SVR, that's what it means. It means that you treated the patient, and 3 months later, you check the blood test, and the Hep C RNA is not there. That is a cure. This is durable. This is good news. Now, this figure shows you a cartoon, and I call it that because this is just a reflection of the type of proteins that were found. And this was the basis for which treatments were developed. Before, those who remember the days of interferon and ribavirin, these are drugs that we never want any medical students, PA students, or nursing students, or anyone to ever have to experience, because those drugs were hard. They caused a lot of side effects. It gave people, the doctors and prescribers, heartburn and fear because you knew you only had about a 40 to 50% shot, and that they were going to have to take it for 6 months to a year, and that you better monitor them very closely, and that they weren't going to like you during and after treatment. Nowadays, we have these medicines that are a lot easier. Note the colorful graphs going up on the right. Starting off, look, 2001, 1998, you have those numbers. And I think the main takeaway is that we are now living in a new era. We're living in an era where the cure rates are very high. The challenge then is, how do we go from this science to these cure rates to implementation. I think that's been the last leg that people in the field are working on. Here is a table. These are medications. We're not dealing anymore in the era and time when these first came out. I remember filling out a lot of forms, writing letters of appeal, trying to get people these medications. What I think is important for this audience to know is not specifically the names or the fact how long you can treat. You can just look this up very easily. You can look at my notes. There is a well-made website called HCV Guidelines. And if you Google that, you can see the latest Infectious Disease Society of America and the American Association for the Study of Liver Disease. That is a very helpful guideline so that you don't have to call up your local ID doctors who have their hands full dealing with mycobacterium and staph and everything else, right? So you can look it up and it'll help identify which products are out there. I think the hard thing next is then you can engage the patient and have the conversation. There is a cure. We will connect you to care. Treatments are very tolerable and it's very limited. This is the messaging that I think is important. Now, I don't have time today to talk about ECHO, which is this kind of remote monitoring and treatment with specialists working with primary care providers in the community. Does anyone here have any experience with that kind of program here? No, so this is something that you can also Google or look up. This started out in New Mexico. New Mexico is like Oregon in that they have Albuquerque and Santa Fe. And then hours away, you have these places that are very remote from medical care. Reservations, places that have no primary care doctor, but they might have a nurse practitioner or a PA. Essentially, there was a teaching, there was ongoing follow-up specialists providing support to the local front line, and they in turn treating patients with viral hepatitis. It's proven to be very successful. Anyway, these medicines are out there, they work, and I encourage you just to be familiar. Two things at the bottom, one in black and one in red. Red means be aware. This is something to be aware. If any of your patients go on these kinds of medications, just like if you're an oncologist, you need to be aware of the viral hepatitis B settings and serologies. If you put people on these kind of medicines, Hep B can awaken. I compared this to kind of like a gangland analogy. It's because I grew up in Chicago. It's like you had a major gang that ran a neighborhood. That was hepatitis C. And there was a lesser gang called hepatitis B. If you come in with a cop force and wipe out hepatitis C, it's going to create a vacuum. That Hep B gang is then going to take over and start proliferating. So that's what happens if you knock out Hep C very quickly, as these medications do, the Hep B can reactivate. This is similar in the mechanism and awareness of oncologic medications and immunosuppression that can reactivate Hep B. The other thing is, technically, there's just some limitations on using certain drugs when someone has decompensated liver disease. So I think this is an important point. If any of your patients come back to you from infectious disease or GI doctors, you sent them, they got treated, they're cured. And then somewhere along the way, someone checks a Hep C antibody. It will remain positive. They do not have Hep C again. This is a common complaint and fear. The antibody will remain positive, so you need to tell them. Flip side, if they get exposed to Hep C again, that antibody will not protect them. If they have some underlying substance use disorder, that's something that needs to be connected. And very importantly, as I mentioned earlier, if they have advanced liver scarring, that is stage 3 or 4 fibrosis, they remain at risk for liver cancer. I put 3/4 because sometimes it's very hard to distinguish. But definitely, if someone has stage 4 fibrosis or liver scarring, that person, in bold, needs to get an ultrasound and alpha-fetoprotein every 6 months. I tell you, this is a very common thing that GI doctors are cited for not doing. Either they didn't recognize that this patient had cirrhosis, and if they recognized it, did not institute liver cancer surveillance. So I urge you, if you're a primary care, if you're in that field, note that. That's a very important clinical pearl. Questions on Hep C before we go to Hep B? Yes, ma'am. Yes, so Hep C antibody, you mean for the diagnostics for Hep C?
No, to follow up.
Yes, so let's say you start today. They finish their treatment 3 months later. 3 months after that, you order a Hep C RNA. If that comes back negative, that person has that fancy pants word, sustained virologic response or cure. You can then tell them, you are cured. Go forth in peace. Don't be reinfected. That's, I think, an important follow-up. Yes, sir? Yeah. Question is, what do you recommend for hepatocellular carcinoma surveillance? Guidelines are a minimal scaffolding. That is, they provide us the minimum you have to do. The major guidelines that are cited by insurance companies and by those legal entities which define standard of care suggest at least an ultrasound of the abdomen, plus or minus alpha-fetoprotein. Card-carrying liver doctors like myself always do the alpha-fetoprotein. Not because I think the alpha-fetoprotein is very sensitive, it's only 40% sensitive, but because I look for a delta or crescendo over time. If I see something that was normal and it goes up a little bit, and then it goes up a little bit more, and then it doubles, that's what alerts me to think maybe the ultrasound did not find it. Now, that's the minimum. If you have somebody with a very big abdomen, and if you have somebody who has perhaps some kind of scar tissue or something that interferes technically with the ultrasound's capacity, that's where cross-sectional imaging, unfortunately, is required. Yes, sir?
Would that be treating also for hepatitis B cirrhosis as
Yes.
well as hepatitis C
So
cirrhosis?
this surveillance recommendation I just made for you is universal for all cirrhosis. It is cost-effective, and there's good data for that. Now, within cirrhosis, there's stratification. What's higher risk, what's lower risk? I think that's too much. If anyone has cirrhosis, you should treat them at risk for liver cancer. Great questions, thank you. All right, Hep B epidemiologic summary. The one in red tells us, again, the why. We have a lot of people, 300 million people worldwide. There are at least 2 million in the US. Why is acute Hep B rising since 2014? Can anyone guess? Actually, it's rising more since 2020. Yeah, it's the rise in the fentanyl shipments coming up. It's the rise in methamphetamines, the persistent nidus of Hep B in our populations. So there's a steady state of vertical transmission in the populations that's at risk, but the type of behavior that leads to an increase in Hep C, HIV is the same as that which increases that risk for Hep B. So we're going to be seeing that. Many people who have Hep B are unaware. It is also a source of shame and a source of a topic that is not discussed in most families that have this. Look at the number and percentage of people on treatment. It is very low. Why? The population that has this are the type of patients that you like and I like. Why? What do? They show up, they never complain, they don't ask your nurses for anything every two weeks with some new complaint. So they're not the ones that are going to be pushing you. So we have to know what the indications are and try to treat them. Note here also that because of this virus, more than a quarter of those who are affected die prematurely. Pardon me, is there a clock for me to see where it is? Okay, yeah. Can you tell me what time it is? Yeah, it is 4 or 5:24. Okay, thank you. Thank you so much. All right. Yes, that'd be great. Thank you. Hep B modes of transmission. This is a figure again, and the thing that I want to point out is look to the right, the mother to infant. It's a very sacred bond. We pass on our traditions, we pass on our loves, our foods, but a mom should not be transmitting a virus to their child. But in the biggest parts of the world, that is the most common route and means by which Hep B is transmitted. Why? Because not everyone knows that they have Hep B. They may know they have it, but don't realize, or their providers don't realize, if you give HBIG, which is Hep B immunoglobulin, and Hep B vaccination, you can prevent transmission up to 90% of the time. If you don't do that, up to 90% of the time the baby will get it, and once the baby is infected, they will have it for life, and then serve as the vector or the means by which the next generation. This reminds me to tell you, if you have somebody with Hep B, take a family history, ask about who else has it. You will find inevitably somebody 1 or 2 layers up who had it. Ask about if they had anyone with family history of cirrhosis or liver cancer. These are the things that make me tilt them toward treatment with that kind of history. If you do this kind of history, you can get their other family members vaccinated, and you can break this cycle. This I will have you read. The incubation and clinical features very similar to hepatitis C. Note here how unfair it is. Clinical illness, very low if you're exposed as a baby. Why is that? I think just thinking about it from a layperson's perspective, younger person's immune system is not as robust. They also have been exposed to mom's blood. They've been in the womb, and so they tend to accept Hep B when they're exposed to it. Thus, it doesn't elicit a strong immunologic response. In contradistinction, someone that is in their teens, 20s, or 30s, which in the US is a common other way, sexual exposure, intravenous drug use, intranasal cocaine use, other means, blood exposures, hospital-acquired, work-related. You get exposed as an adult. You're not vaccinated. You're more likely to have a very strong immunologic reaction. That helps you not to have chronic infection. But then the adult person who's infected, as I'll talk about similar in Hep A, is the one that might go into liver failure because of an over-response to the infection. That leads to the cells that have infection being killed. That's what liver failure is, liver cells being killed. Mortality, I think this 25 to 30% again underestimates it. We don't have as good long-term natural history studies. These tend to come from Asia or Eastern Europe. But in the United States, again, I think these numbers are probably too low. If you have Hep B, you're likely going to have some part of your life impacted, and your patient will have a shorter life and a less good quality of life because of that. This looks a little complicated, but I'll walk you through it. So you start with acute Hep B infection on your left. You notice that some people have subclinical hepatitis. If you get hepatitis B, you typically tend to be symptomatic. These are the ones that come to you with right upper quadrant pain. They're in the ER with jaundice. Remember I said nausea, vomiting, anorexia, diarrhea. But if you're an adult, you recover. Look at the bottom right figure. If you're a kid, less than 5 years old, you're unlikely to recover from this. You're going to have chronic Hep B. Thankfully, only a small percentage have acute liver failure or fulminant hepatitis. These days, we can treat them. In the past, can you believe it? Until newer drugs were available, Hep B was a contraindication to liver transplantation. That's not that long ago when the drugs like lamivudine came out. So these drugs that have become available are now helping Hep B to become one of the easiest type of patients to manage post-transplant. They do very well. Why? Because the medicines help to control viral replication. The next 2 slides always are challenging, so I'll warn you now. Look, I only put 3 things on here because whenever I give this talk, everybody starts to look away and they start yawning. Why is it hard? Because you got to memorize this. There's no logic to this. There's no story behind it. I mean, there is a story of Australia antigen and so forth. But I urge you just to memorize this because this will help you interpret. There's 3 things here. In essence, if your surface antigen is positive, it means you are infected. If your surface antibody, that's the second row, is positive, you are immune, you are protected. That's different from the Hep C antibody. You can have all the positive Hep C antibodies you want. That does not protect your body. But if you have an antibody to the surface antigen, as you can see here, you are protected. Now, the third one is a often test that's used in board questions, but a core IgM positive is something that is run as part of an acute hepatitis panel. So if you order that in your medical record system, or if you tell the ER to get an acute hepatitis panel, that's typically included. If that's positive, that should alert you that this is an acute and recent infection. If that wasn't enough, slide 2, Hep B DNA. So Hep B DNA, the way I think about it is like Hep C RNA. It helps confirm that there is virus floating around in your blood. But in your mind, you should think the higher it is, the higher the risk of liver cancer. That's HCC, hepatocellular carcinoma, and cirrhosis. Now, for those who are going into GI, I then make them memorize the last two, the E antigen and the E antibody. Why don't I challenge you to do it? Because it is not as important. It is more important for the person who will be managing the treatment initiation decision and the withdrawal discussions, which I think are important to be aware of, but it adds too much to the complexity. It's not that you can't do it, but you don't have 27 hours to do all the things that you should. So I interpret it as such. E antigen's positive, very active wild-type disease. E antibody positive, it is inactive. That's a very simplified form. This one, I encourage all of you, whatever field you're in, please look at this. Why? Because every once in a while, the kind of questions I get, which I usually turn down, is from some law firm saying, hey, we have an oncologist who started somebody on rituximab. Oh, unfortunately, they forgot to check the Hep B core antibody and their hepatitis serologies. The patient went into liver failure and is now unable to get chemo. Thankfully, they were able to salvage them with antiviral therapy, but now they're getting calls about missed diagnosis. Hep B core antibody is something often misunderstood and often overlooked. And I emphasize this in all the medical education that I do in our school and our PA in nursing, because it's not often well covered. Core antibody means your patient has been exposed in the past to Hep B. Scientifically, it is a marker of covalently closed circular DNA. That's that cccDNA in the second line. All that means is there's a hidden sleeper agent in your body from the Hep B infection. Even though it's not floating around in your blood, you don't see the marker surface antigen showing you to have active infection. It means the patient was exposed and that there is a sleeper cell. This kind of patient who has this is a marker. Anytime you suppress the immune system, the more you suppress it, this sleeper cell, no pun intended, can reawaken and cause an active hepatitis and be very severe when that happens. So I would urge you to look at this and remember it. It'll hopefully spare you trouble. This slide I put in here for your studying and learning. It just breaks down what it means, each of those, and the interpretation. I'm going to look at the third, so let's say 1, 3, 4. The fourth line. Surface antigen is negative. The core antibody is positive. It means no active infection, prior exposure. The IgM is negative. So prior exposure, it's not recent. The surface antibody is positive. Okay, this means you are likely exposed and you have developed an immune response. You're immune. But this person is at risk for reactivation based on the core antibody being positive. In contrast, look at line 2 and 3. The only difference between acute and chronic, simply speaking, is they both have surface antigen. That's infection. Their core antibody is positive. They've been exposed, makes sense. But the IgM is positive in the patient with an acute infection. And neither of them have the surface antibody. because that would imply protection. This one can help you to avoid sending somebody who has an isolated core antibody to a consult. This line, again, this kind of person does not need to be sent to your GI or ID or hepatology consult unless you're going to put them on immunosuppression. It's treatment goals of anything. What do we want to do? We want to prevent death, cancer, badness. However, in real life, I think most providers, if you've been in the work for a while, you realize sometimes you're just a catcher in the rye. You're trying to hold the door from being burst open by all the diseases. So similarly, hepatologists have accepted surrogate goals. That is, we can't treat someone 10 years and see if they die later. We don't have that kind of good data. But we do have markers that tell us if the treatment is working. A little bit technical, but it's simple. Are they feeling better? Are their liver enzymes normalizing? And is their virus levels going away? And is it going from active disease or to inactive disease? The bottom line is this loss of surface antigen. If you remember, surface antigen means infection. So if you lose that and you develop a surface antibody, you are now in an immune state. That will be great. Unfortunately, this happens at about 1% a year on treatment. That's a long time to get to cure. Who do we treat? Everyone who comes to you and found to have cirrhosis and has Hep B, you should treat. The bottom two are the type of blood test parameters and scar tissue parameters. Not so important, because all that means is if anybody has elevated liver enzymes and has elevated DNA and has scar tissue, you should err toward treating. Why? Because treatments are well tolerated. Treatments are covered by most insurances. 3, these are treatable. If you can suppress the virus, reduce the DNA, and if you remember I said DNA is a marker for cancer and liver decompensation, you can bend the curve and help the patient live longer and better. This is a figure that talks about the treatment landscape and currently. I think this must be the PDF, so it doesn't have the nice little graphics, and that's just as well. These medicines in red are the ones that are currently recommended as first line. What should you take away from here? First, there are treatments. Secondly, you've got multiple choices from them, and that these treatments work, and that they have improved. I would like you not to use any of the ones crossed out, and the one here called lamivudine is not something that I would advise. We only keep it there because sometimes that's the only one that's covered by insurance, and we have to fight that, but that's oftentimes the last thing that we reach for. We don't like it because it leads to resistance and it stops working half the time after 5 years. This is a summary slide, and I'm not going to go into it too much for this audience, except note that you have choice. Note that there are some comments here about the kidneys and the bones. Why? Because medicines, like anything in life, is double-edged. There are some risks. There are signals that on an absolute level, several percentage points. That is, if you put people on these medicines, you got to keep an eye on their kidneys and keep an eye on their bones, because these things are known to have mild abnormalities. Now, this is a figure I put in for us to just understand. If and when your patient is put on Hep B treatment, if you have active disease as shown in the yellow, E antigen positive, we can have a goal of making it inactive by making the E antigen go away and the E antibody positive. Now you see why I didn't go into this on that second slide, right? This is like, it has confusion. But if you take away from the slide 2 things, look at the bottom right. Some people need indefinite treatment. Those are cirrhotics and people who have E antigen negative. Why? Because as of now, we don't have good data to know when to stop. And so this is a point of pause and concern that I always have with patients. I am, as you can tell, I'm a proponent for trying to treat patients because I think they're underserved and undertreated. But before I commit someone to treatment, I say this could be a years in the making. We're looking at 8 to 15 years before next generation drugs come out, where it might be short-term and cure. But right now, if it was me, I would take one of these drugs, and I would take it indefinitely until next generation drugs that can convert to cure could come out, based on my experience. Others who have the one in yellow, you can try to treat and stop. What are the limitations? Well, we're not really trying to cure people. All these medicines do is affect the reproduction. We heard the story about the tattoo. I'm curious to see it from here, this angle. I think I have a view of the top of our previous speaker's head about the adherence story, right? If you can't take it medicine for hair growth for 12 months, how are you going to take a Hep B medicine for which you have no symptoms for 10 years? Also, despite our sanguine comments about safety, we don't have data 20 years of somebody being on this drug. So we have to be honest and say, best data we have looks fine, but we're still continuing to observe and monitor. And then finally, the issue about cost, our ballooning healthcare system. Now, this was supposed to be a build, but I think this is just a cartoon. Suffice it to say, next generation medications are out there. And what's driving this? Besides the love of science, besides people wanting to build their careers, academic careers, right, in their white towers, trying to build their academic careers, this is driven by money because there's a large population. If we speak honestly, you got 290 million people, and if you can figure out a cure, that will really help a lot of people. So I'm hopeful that that will drive and that will allow newer things to come out. And we as providers can harness that to help our patients. So I have some hope. However, even after making this kind of slide, several of these have fallen off due to adverse events or effects and so forth. So this is a rapidly changing area. Now, pregnancy. Whenever I get called about a pregnant patient, I don't know about you, unless you're in OB-GYN, I really get a little nervous, especially in the inpatient setting, because that's bad when a liver doctor gets called to a pregnant patient's bedside because they're very sick. But Hep B, takeaway, if you can find patients with Hep B, you can educate them and their providers about prevention with Hep B immunoglobulin and Hep B vaccination for the baby. Remember, you reduce the transmission from as high as 90% to less than 10%. And there's good data now that if you find these patients and their viral load is high, you give them short-term 3 to 6 month antiviral therapy, you drive that percentage down even further. This is that buildup. I've given you some buildup about the core antibody positive people who have Hep B. If you give somebody immunosuppression and they have these conditions, this can lead to reactivation, which can be severe. These type of patients should be prophylaxed. I advise referring this type of person to your local ID, GI providers, because this will, a little ounce of prevention can prevent a big headache later. It is short-term. You can start it the day of or the day before the immunosuppression is going to happen, and you continue it for about 6 to 12 months. You never know what could have happened, but you can rest knowing that you have done what needs to be done to prevent reactivation. I'm going to skip these next 2 slides. I think you've had a talk on that earlier about prevention and public health. So I'm going to try to use the rest of my time to focus more on this aspect here. Note the 20 to 30-year timeline. Unfortunately, if you're in peds and you're in an endemic country, you see things like cirrhosis and liver cancer in a 12-year-old. This was very routine in Asia and parts of the former USSR, where you have vertical transmission, baby infected, active hepatitis, early teenage years abdominal pain, ruptured hepatoma or hepatocellular carcinoma. But there are many things that we can do, and this is where public health is important. Vaccination efforts, post-exposure prophylaxis. Where we are is secondary with chemo prevention, and then the liver cancer surveillance, as we were talking about, with ultrasound and alpha-fetoprotein. And then if these people come and have cirrhosis and liver cancer, then they come to a quaternary center such as we have, and we talk about liver transplant and multidisciplinary, thank you, multidisciplinary liver tumor conferences. All right. Questions on Hep B? All right. All right, great. Yes, I've been given the placard by the awesome timekeeper in the back, so thank you. All right, I'm going to speed up a bit, and the rest is pretty quick. Why is that? I would challenge anyone here to raise their hand if they've seen Hep D, as in David. Yeah, has anyone seen it? Our ID doctors? And you know why we don't see it? We just don't test for it. So you don't see what you don't test for. It's a defective virus. D is for defective. Remember, if you get 2 viruses, it's worse than 1. D always needs Hep B. So you can only get Hep D if that person already has Hep B, or you get exposed to someone who has Hep B and D together. Co-infection and superinfection, these are definitions. The concept is you have a patient who had chronic hepatitis B. They get exposed to Hep D. That's superinfection. On the other hand, you have somebody with no prior disease. They get exposed to somebody with Hep D, which always has Hep B. That's called co-infection. It's not that important, except that this is actually a common thing. We actually think worldwide there's 15 to 20 million. And unlike Hep B, it's a rapid cycle to cirrhosis, liver cancer, and liver complications. There's parts of the world that we know, and most of the world we don't know. This is a definition here. Takeaway is that if you're co-infected, that means your body never saw Hep B before. You're likely to have, especially as an adult, a very strong immune reaction. And if your immune reaction is so strong, you're likely going to have an overreaction and liver failure. Superinfection, on the other hand, you already were marked with Hep B. You got infected with Hep D, and now it just speeds up the timeline, but not liver failure. So what do? Prevention, prevention, prevention. You want to vaccinate for Hep B, because if you're Hep B vaccinated, you can't get Hep D. You diagnose it. The test you send out, I heard LabCorp earlier, Hep D antibody is available. It should be available at your local Quest or as a send-out from your hospital. Hep D RNA is harder to get, but the antibody is a start. And then refer for treatment. Newer therapies are coming. I think it's an exciting time. I'm not going to have time to talk about it here. What do I tell everybody who has viral hepatitis? Don't drink. Don't go to the Tri-Cities. Don't go on wine tours, because that's what drives your liver to get sick. Don't forget the Hep A vaccine and education. Now, who should you refer to your local specialist? Take a look. Think about who you might refer. 20-year-old, right? That one, that's just an exposure. Doesn't have chronic Hep C. Hep D, nobody ever finds that person, and you should refer that. Liver mass, could be cancer. Jaundice and ascites. These days, we see a lot of alcohol, and that's the first thing that comes to mind when I hear that. That's someone that might need a liver transplant. Abnormal LFTs, PCR positive means the RNA of the Hep C is positive. Incidental cirrhosis. And the final person, core antibody positive, not going to be on immunosuppression. So you don't need to refer the first person. And number 5 and 7, I put that in orange because that's the person that in some primary care circles, some people are treating the Hep C, and the bottom one, they're keeping an eye on in case they're exposed to immunosuppression. Hep A. Now, I was asked to talk about Hep A to E by the organizers, and I realized looking at the agenda today that there's been a great effort and discussions on public health aspects. So this part has some more data, but I'm not going to go into it as much as our public health experts have. I will summarize by saying we're seeing a lot more of this. If you see the news, you're always seeing somebody at Wendy's or Chipotle or wherever you get your groceries having acute hepatitis. It's not your imagination. It has been going up quite a bit. If you're living in an area like where I come from in Portland, there are a rise in, there's a housing crisis. If you're from Seattle, you know this. I'm sure you have this here. That is an epicenter of hepatitis A. These are the percentages, and you can see here, it's getting worse as of 2 years ago. I don't have the latest from last year because it's so recent. And it presents as an acute hepatitis. Thankfully, almost everybody gets better on their own. Less than 1% go to liver failure. Who gets it? 50-year-old school teacher who had a Hep A exposure at school. That's the classic case. And there's these two things, cholestatic and relapsing, that I'm not going to talk to you too much about. I put it in here because of time. But this is the pattern that you see. Sick, ALT goes up. The IgM, which is again a marker of active and acute exposure, goes up. And then you get a protective IgG that goes on. If you have a Hep A antibody, you're protected. It's worse in adults for all the reasons I talked to you about immunologic response. And at most, you typically get transaminases in the thousands, barely less than 10. What's cholestatic Hep A and relapsing Hep A? Essentially, it just means, unlike most people, some people have ongoing hepatitis. Key thing is, don't overreact. This happens. Reassurance. Similar, relapsing, they got better. 3 months later, they got jaundice. You, of course, have to investigate for other things, but most likely this is a relapsing of hepatitis A. It will get better. When I see them, I reassure, I just follow their LFTs. And if their INR is normal, and if their mental status is okay, they're not in liver failure. So that's fine. Finally, Hep E is something that's even rarer than Hep D because we test even less. But it is actually among us, farming, hunting, fishing. It is in the US, whether we know it or not. It's the most in developing areas, but there are national studies that show prevalence. It presents as an acute hepatitis, very similar to other ways. Most recover, but some studies say you can get jaundice and cholestasis for up to 3 months. Percentage of these come as liver failures, and if you're immune compromised, you can have chronicity. Most people get sick, they don't even know they have Hep B, no one ever diagnoses Hep B. All you know is they went to the hospital, got jaundice, and then 3 months later they were fine. If, however, you want to investigate this IgM, and you can check for RNA and stool tests. This is not easy to find, but your labs, I've called around, most labs now will send a hepatitis E IgM. What do? You provide supportive care. There's no vaccine. Maybe that sounds kind of resigned or fatalistic or nihilistic. But the key thing is, thankfully, most people don't get sicker, but I'd like you to be aware of it. And that if you have someone that's mysteriously having this, think of it. When I see these people, it's in the immunosuppressed setting, and there are therapies available, such as ribavirin. So in summary, before I get kicked off, Hep A can lead to chronic cholestasis. It can be relapsing, but most people get better. Hep E, think about it, be aware of it, keep an index of suspicion. It'll make you look great if you diagnose this in your hospital. Hep D is co-infection and superinfection. There's a difference. Co-infection can lead to liver failure, superinfection, worse outcomes. And Hep B and Hep C, I say basics, but whatever field you're in, you need to know that surface antigen means chronic infection. And I hope you have taken away that core antibody is not something to be feared, but something to be checked. So with that, I hope that all of you are organ donors, and I'd like to encourage us to all to give thanks and give life, and I'll take any questions. Thank you. And it says the end, which means we are done. And I'll stand here unless somebody has any questions. I'm happy to take questions so we can get everybody else home. Thank you very much, organizers, for this opportunity.